Hi, good evening, everyone. I am Dr. Pramod Sharma, working in the Department of Accident and Emergency in Max Super Specialty Hospital, Vaishali. Today, we'll be speaking about the blunt trauma to the abdomen, mostly seen in road traffic accidents. And we'll be speaking about the most common injuries, the most common organs that are injured, and how we can manage them in and outside the hospital before the patient is eventually brought to the hospital. So, good evening, everyone, again. So, we'll start speaking about blunt trauma abdomen. So, before we start about the trauma to abdomen, let's see the disease burden that is brought by the road traffic accidents. So, on the scale of the global problem, we deal with around 6 million deaths per year caused directly or indirectly by the road traffic accidents. It poses a huge disease burden, resulting in almost 10% of the global deaths every year. That is more than 32% more deaths combined due to HIV, TB, and malaria. So here we can see the global road traffic injury mortality rates country-wise. India accounts for almost 6% of the road traffic accidents and for nearly 11% of the global deaths caused due to road traffic accidents. That is around 4.5 lakh road traffic accidents per year, out of which around 1.5 lakh people die every year in India. So, trauma is one of the most common causes of death, specifically in the young population, in which abdominal trauma it stands next to head injury and chest injury. Almost one fourth of all the major trauma victims require some sort of abdominal exploration, which is a very challenging component because of mostly due to the hidden nature of injuries. The abdominal trauma, the injuries caused by the abdominal trauma are not very evident. They may not be very evident at the first go. So penetrating torso injuries between the nipple and perineum, that is a potential cause of interrupted abdominal injury. The so they can be the priority and assessment methods of the patients. They can be determined by scene specific factors, the mechanism of injury, the force and location of injury, and most importantly, the hemodynamic status of the patient. 75% of all the blunt trauma in to the abdomen, they are caused by road traffic accidents. Others may be due to assault and other factors. And out of the 60% of the injury occurs mostly in males, that is in the younger population, 40 to 30-year-olds. And we can see a trimodal pattern of mortality due to trauma. So here we can see the trimodal distribution. So there is a golden hour here. In the first hour, usually the 50% of the victims, they die almost instantly or within a few minutes. And another 30%, they may die due to shock in the first hour, in the first few hours. Later on, around 20% of mortality occurs due to the sequelae, which may be due to complications like infection or multi-organ dysfunction syndrome. So the rapid trauma care, it has the greatest level of impact in these 80% patients, that the 80% victims that we lose in the first few hours due to trauma. So coming to abdominal trauma, let's speak about the anatomy and physiology of the abdomen. First and foremost, we can divide the abdomen into 4 quadrants: the right upper quadrant, lower quadrant, similarly the left upper quadrant and lower quadrant. The right and left here, to be noted, refers to the patient's right and left, not the examiner's, not yours. So quadrant of the quadrant where the bruising or pain occurs, that can delineate which organs are involved. This slide shows the right what all organs lie in which quadrant. For example, right upper quadrant has liver, gallbladder, duodenum, pancreas. Right lower quadrant has large and small intestines, the appendix. Similarly, left upper and lower quadrant has stomach, spleen, the colon, and half of the transverse colon. Again, here showing the 4 quadrants of the abdomen. Right lower quadrant is most commonly the location for swelling and inflammation. The appendix lies here, which most commonly can cause infection if it ruptures due to the blunt trauma. Now, speaking of the abdomen, the organs inside, we can classify them broadly into hollow organs and solid organs. The hollow organs are the stomach, intestines, the ureters, the bladder. These are mostly the organs that are containing with some sort of infective material, digested food, urine, feces, and bile. So when there is a rupture or a laceration to these organs, the contents may spill into the peritoneal cavity, causing inflammation, causing peritonitis, and the patient will land up in shock in hypertension. Now, again, the intestine, small and large intestine, as we can see here in the picture. The small and large intestine, their intestinal blood supply to them comes from the mesentery. The mesenteric compromise may occur in blunt trauma, especially in the seatbelt injuries, which can lead to an infarction and necrosis of the intestines, and which can be delayed. Again, the presentation, as we spoke earlier, the injury may not be visible, it may not be apparent at the time of contact, the first point of contact. Coming to solid organs, the liver, spleen, pancreas, these are solid masses of tissue. They have a rich blood supply, so the hemorrhage here can be severe. The patient may land up in shock, hypotension, and shock. Injury to the abdomen broadly again can be classified as open or closed. We will be speaking mostly about the closed injuries due to blunt trauma. They can, again, both the open or closed injuries can involve hollow and solid organs, either one of them or both of them. The most common injured organs, the major organs are spleen, liver, and small bowel in that order. And then in around 15% patients, we can see retroperitoneal hematoma, which again poses a challenge. So blunt trauma to abdomen without breaking the skin, the mechanism of injury or the modes of injury. They can be caused due to steering wheels, the bicycle handlebars, motorcycle collisions, falls. It can be due to compression, that is poorly placed lap belt while sitting in a car or being run over by a vehicle. There can be deceleration forces. For example, when a car strikes a stationary object like a wall or some other object on the road, there can be a massive deceleration, and that impact can cause severe and serious blunt trauma to the abdomen. So signs, symptoms of these blunt injuries can often be very deceptive. The pain usually is diffuse in nature, and the pain may not be where the injury is. It may be referred to another body location. For example, we have the Care sign, which we'll come to later. Similarly, blood in the peritoneal cavity, it can cause acute pain in the entire abdomen, and again, it can present with signs of peritonitis. It can, all these factors make determining the location of the pain a little difficult. There are different signs that we have. For example, there may be guarding, there may be abdominal distension, abdominal bruising and discoloration may be there, which can again give us some diagnostic clues. There are some signs, again, we'll come to them in later part of the presentation. So as we said, the compression in the mode of injury, compression like a poorly placed lap belt. So seat belts, while they prevent many injuries and save lives, they themselves can cause blunt injuries of abdominal organs. They can cause bladder injuries to pregnant females. They can cause mesenteric compromise when the lap belt or the abdominal belt is placed poorly. Airbags, they are a great advancement, although again, they may play a role in the seatbelt injuries again. So here is a slide showing some incorrect positions. Like we can see in the first two pictures, the belts are placed a little higher, and again in these conditions, as we can see in the picture, it can cause some mesenteric compromise and can lead to the infarction of the bowel. So hollow organ injuries may have some, the signs and symptoms may be delayed. There can be rupture of the hollow organs in blunt trauma. In penetrating injuries, there can be a direct injury, but since we're speaking about blunt trauma, so then there's more of the organ pops into the abdominal cavity. That can lead to spillage of the contents, and the infection can develop, which can again take hours or days, leading to a delayed presentation. Stomach can cause can leak highly toxic acid. Again, intestine can lead to spillage of the bile, which can again be a serious irritant to the peritoneal cavity, can cause peritonitis. Um, as we spoke about it, blunt trauma, it usually causes organs to pop, and the organ will, due to the immense pressure and the impact, the organ may just pop and lead to spillage of the contents into the abdominal cavity. Gallbladder and urinary bladder again can undergo the same trauma. The contents again will be damaging. All of these things in the peritoneal cavity will cause immense pain and inflammation, which can again lead to hypotension, shock. Air in peritoneal cavity can again cause pain and eventually may lead to infarction and ischemia. So coming to solid organs, since they have a rich blood supply, they can cause some significant bleeding and can cause rapid blood loss. It is important to identify the risk of this of such hemorrhages, and we need to have a high index of suspicion in such injuries. There may be a frank rupture of, let's say, the spleen or the liver, which can cause a massive hemorrhage, or there may be small lacerations which may cause the blood to slowly ooze out into the peritoneal cavity, again resulting in a delayed presentation of the signs and symptoms. Liver is the largest organ, so it's highly vascular, and it can cause some serious massive hemorrhages, can lead to hypoperfusion. It can often be injured by the fractured lower right ribs, or again penetrating trauma can be a reason for liver injuries. Care sign is again a common finding with injured liver, where there is blood in the peritoneal cavity, and the pain may reflect to the shoulder. Instead of the site of injury, the patient may be complaining of the pain in one of the shoulders. Again, coming to spleen and pancreas, again, they are also very vascular, again, prone to very heavy bleeding. Spleen is the most common injured organ in road traffic accidents, motor vehicle collisions, steering wheel trauma. They can be fall from heights or motorcycles or bicycles, the handlebar injuries. All of these can cause splenic laceration or splenic rupture. The diaphragm, while mostly injured in penetrating injuries, not seen so much in blunt trauma of abdomen, but again, it may cause the patient to have dyspnea, and it may cause some difficulties in the examination. One thing that that can be noted is that the bowel sounds can be heard during auscultation of the lungs in case of diaphragmatic rupture. Kidneys, they are located retroperitoneally, very vascular, so again can cause significant blood loss. One important thing to note will be hematuria, and the visible blood on urinary meatus will usually indicate a significant trauma to the genitourinary system. So what is important here is that detailed physical examination in all trauma patients is very important. So blunt abdominal trauma, it can be due to direct impact or due to movement of organs. It can be due to compressive stretching or shearing forces. And as we have gone through so far, solid organs can lead to blood loss. Hollow organs can lead to blood loss as well as peritoneal contamination. And retroperitoneal hematoma, again, it can initially be asymptomatic, but again, as we spoke in kidney injuries, there can be some serious hemorrhage and that may lead to hypoperfusion and shock in the patient. So assessment of abdominal injuries, it is a little difficult. The causes of injury may be apparent, but the resulting damage may not be very apparent. The patient may be overwhelmed with more painful injuries, for example, the fractures, or some other cuts and lacerations elsewhere. The pain in most of the abdominal injuries may not be very easy to localize. It may be more diffuse, it may be more dull, and it again, the pain might be superseded by some other bone injuries in most of the road traffic accidents, for example. So these injuries may develop over time or they may worsen over time. So reassessment of such injuries is very important. So patient assessment steps when we speak about that, there is, first of all, we have to take a scene size up. We have to work upon what could be the probable mechanism of injury, and that can give us an idea about the mode of injury and the severity of the possible abdominal traumas. The primary assessment of the patient, the history taking is again important. Then comes the secondary assessment, and after all of that is done, as we spoke, reassessment. That is one of the most important steps, because the injuries in blunt abdominal trauma, they may develop or they may present later on. So scene size up. First of all, scene safety is very important. That is when we are speaking about the pre-hospital care. So information that we get initially, it may be a little sketchy, it may be a little vague. Standard protection measures have to be used. At least gloves and eye protection has to be a minimum. Whenever you are at a scene of a road traffic accident or any other scene leading to the trauma to a patient, first of all, you need to make sure that the scene is safe for you. The mechanism of injury, the nature of illness, this has to, the scene size up can give us early indicators of the probable modes of injuries. The spinal precautions we have to be sought, they have to be considered. In case there are penetrating wounds, the object of penetration, that has to be inspected, and we have to take a clear note of what exactly is causing the injuries. So for pre-hospital information, when we are coordinating with the hospital, we can remember this by the acronym MIST, that is mechanism of injury, the injury is sustained or the injury suspected, then the signs, the vitals of the patient on the scene and during transport, and the treatment has to be initiated. So the goal, the most important thing I believe in the entire presentation for pre-hospital information, pre-hospital care, is scoop and run. These are three words that will summarize it. We have to take the patient as soon as possible to the hospital, because as we said, abdominal trauma, the evaluation, the workup, the assessment, it may be a little deceptive. And the airway has to be maintained. If possible, an IV line has to be started. Again, the spinal cord has to be taken care of. Clear and crisp communication is important. And again, rapid transport to the trauma center. Patient should always be evaluated at the highest possible trauma center nearby. So a rapid transport is very important. Coming to the primary assessment, the primary assessment always has to go with ABCs, the airway, breathing, and circulation. A rapid scan should be done. That will establish how serious the condition is. Some injuries may be very obvious, they may be very graphic, others may not be so much, and they may be subtle, and thereby they may go unnoticed. Some injuries may have occurred hours or days earlier. So we need to make a general impression, important indicators that can give us an idea of how serious the condition is. And as we spoke just now, that some injuries may be very, very graphic in nature. So we should not be distracted for looking for more serious hidden injuries. Patient has to be assessed for their responsiveness. We can use that by the AVPU scale and if possible, the Glasgow Coma scale. AVPU is if the patient is alert, the patient is responding to verbal commands, if the patient is responding to painful stimulus, or if the patient is altogether unresponsive. So again, coming to airway and breathing, we must ensure if the airway is clear, it is patent, the patient can breathe properly. Spinal injury has to be checked for. If there is vomiting, the airway has to be clear of the vomiters. The nature of the vomiter should always be noted, whether there is blood in it, whether there is bile in it. The color of the vomiters can give us an idea of that. Again, distended abdomen due to whatever reasons, it may prevent adequate inhalation. So oxygenation is important. The patient should be shifted with oxygen. Providing oxygen will help with oxygenation of the patient. Coming to circulation, superficial injuries, they usually will not cause very significant external bleeding. However, the internal bleeding may still be profound. The trauma to the solid organs like liver, kidney, and spleen, it can cause significant internal bleeding, which may not be noticeable at the very first instance. So we can check the skin color, the temperature of the patient, and again the responsiveness, how pale the patient is, patient's pulse. All of these can help us determine the severity and the stage of shock, which needs to be treated very aggressively. A transport decision should be made as soon as possible. Again, all abdominal injuries, they will indicate a quick transport to the hospital. Because delay in the medical or proper medical evaluation, it may result in dangerous progression of the shock. The patient will land up in shock, and that golden hour that we spoke about, we lose 50% of the patient within the first hour. That can be prevented if a rapid and a quick transport decision is made in time. So, again, patients with abdominal injuries, they should be evaluated at the highest level of trauma center available nearby. So then we come to history taking. First of all, we need to investigate the chief complaint. Whether the patient has pain, the nature of pain, how severe the pain is, if the pain is radiating somewhere, if patient has some obvious bleeding or some bruising over any part of the abdomen. Further, the mode of injury should be investigated. The signs, symptoms, all of these we need to identify. Negative history becomes important here. Now, any movement of the body or the abdominal organs, it will irritate the peritoneum. The patient will be in pain. So to minimize this pain, patients usually will lie still with knees drawn up, refusing to move or to be moving. So a sample history using OPQRST, this can help us explain the injury. So if the patient is not responsive, we can obviously obtain injury history of the mechanism of injury, or otherwise from the family or friends or the bystanders. So OPQRST will be summarized as the onset of pain, if there are any provocative stimulus to the pain, the quality of pain, whether the pain is sharp, the pain is dull, it is crushing in nature, burning in nature, tearing or shearing in nature. Then the pattern of the pain becomes important, whether there is an intermittent pain, there is a constant pain, or there is a throbbing pain, any radiation of the pain, the severity of the pain, and the time since when the pain has been there. So if there is any nausea, vomiting, again, the nature of vomiting, any bladder bowel movements, all of these have to be included in the history. Coming to physical examination, we have to inspect the patient for bleeding. Any obvious external bleeding has to be sought for. All the loosened the clothes and everything have to be removed, respecting the patient's privacy. Yet we need to remove the clothes and expose all the injuries to do a proper examination. During all this, we should make sure that the patient remains in a position of comfort, and the patient has to be assured, and it will help relieve some tension for the patient if the patient is responsive and conscious. Now, entire abdomen should be examined. If there are any penetrating injuries, the entrance wound should be looked for. Again, if the exit wound also should be seen and noted, and the bowel sound should be seen, which may be a little difficult to hear. They may be hypoactive, where we cannot hear sounds. They can be hyperactive, that is a lot of gurgling and gas moving around. It can give us an idea about the status of the bladder, whether there has been some injury to the hollow organs, that is the intestines. Again, physical examination, we can use decap BTLS. That is, we need to inspect and palpate for deformities. We need to see for contusions, abrasions, any puncture wounds or penetrating injuries. For burns, we need to palpate for tenderness. We need to look for any lacerations or any swellings. The swellings may indicate significant intra-abdominal injury. It can be a result of some sort of internal bleeding and causing some subcutaneous edema and ecchymosis. Now, while palpating, we need to make sure that we palpate the farthest possible away from the from where the pain is localized, where the patient is localizing the pain, and it will allow us to investigate the patient properly. If the scenario permits, I always assure the patient and talk to them before you start palpating for any sort of tenderness or any swelling, because the patient is already in pain. So if the mechanism, if the mode of injury, if it suggests an isolated injury, we can focus the exam on the injured area. We can again inspect for entrance exit wounds in case of penetrating injuries. If there are penetrating injuries and there are impaled objects, they should not be hastily removed. The kidney area, both the flanks, they should be palpated for any tenderness, bruising, swelling, or other signs of trauma. Vital signs in secondary assessment need to be checked. Most of the abdominal trauma, if there is an injury to a solid organ, they can cause a rapid pulse and a low blood pressure due to massive internal bleeding. So recording the vital signs like the pulse and the blood pressure of the patient and the saturation, all of these can help us monitor the changes in the condition of the patient and give us an idea about how severe the possible or suspected internal bleeding is. In closed abdominal injuries, the biggest concern is not knowing the extent of injury at the first go. So again, the patient requires expedient transport, preferably to a trauma center with a surgeon available. High flow oxygen should be started, patient should be positioned for comfort, and shock should be treated on the way. Now, with patients with blunt abdominal wounds, they may have severe bruising of the abdominal wall. They can be liver and spleen laceration, they can be intestinal rupture, again, they can be mesenteric compromise, which may result in subsequent intestinal infarction. They can be injury to the kidneys, leading in rupture or avulsion of the kidneys. So all the patients with blunt abdominal injury, they should be, for both for transport and for examination, they should be log rolled onto a spine position, to a supine position on a backboard or a spine board. It will help us protect the spine. The vitals should be monitored. Now the log roll, it has a specific way to do. So here we can see a little graphic about the log roll. If ideally, there should be 4 people. 1 person should stabilize the cervical spine. 2 people will help roll the entire body, and 1 person can inspect the back and palpate the spine and look for any other injuries that may have been missed in the first row. So coming to resuscitation, it is very important to protect the airway and protect the C-spine. The ABC, the breathing, ventilation, oxygenation has to be taken care of. Shock has to be very vigorously managed. 2 large caliber IV lines and IV crystalloids, preferably ringer lactate in such cases. They have to be arranged. Type specific blood should be arranged as soon as possible, and a surgical intervention, they should be planned as soon as possible. Patient should be protected from hypothermia, and unless it is contraindicated for some reason, urinary and gastric catheter should be put ASAP. Gastric catheters, they will, like a Ryle's tube, will help us ascertain whether there is any other intra-abdominal bleeding, there is some bleeding from the stomach, and urinary catheters can give us an idea about the urinary output, thereby giving us an idea about the perfusion of the kidneys. So some signs that we spoke about during this discussion, the CARE sign. CARE sign is in subcapsular splenic hematoma or again in liver laceration. We can demonstrate this sign where the pain is referred to the tip of the shoulder. We can see here the nerve roots, again C4, C5, C4, C3, C4, C5, which are the nerve roots for the phrenic nerve. They may cause the radiation of the pain to the tip of the shoulder. And the sign, another important sign is balance sign, which is dull percussion in both the flanks. This balance sign can usually be seen in, again, splenic rupture. On the left-hand side, at the location of the spleen, there will be a constant dullness, whereas on the right-hand side, there will be a shifting dullness. That is, with the change of position, we have a dull percussion. Next, there can be great earnest sign, again in retroperitoneal hemorrhage, in kidney injuries, that is bruising of one or both the flanks. There is Cullen sign, that is periumbilical ecchymosis and superficial edema. Now, this sign was first described in a ruptured ectopic in 1916 by Edward Cullen. It can also be seen, what we usually read in medical school, it is a sign of hemorrhagic pancreatitis, but we can also see this in ruptured spleen. So coming to the evaluation of the trauma patient, the first and foremost modality is fast examination, that is focused abdominal sonography in trauma. So this is one of the most easy, the quickest, and can be performed bedside, and with it can give us an overall accuracy of 94.9% and a high specificity and sensitivity of 95 and 94.6% respectively. So there are 4 views of abdomen to look for fluid. In the right upper quadrant, that is the location around the liver and gallbladder, we have a Morrison's pouch. That is the first place where the fluid collects in the supine position. Then there is a subxiphoid view for the view of the heart. The left upper quadrant view, the view of the splenorenal junction, and the bladder view, that is the view of the pelvis. It has largely replaced the deep peritoneal lavage as a modality because one thing, it is non-invasive and it is easier to perform and can be performed easily in bedside. Bedside ultrasound, that is looking for collection in the unstable patient. It can be performed in an unstable patient. And in case the patient is unstable and we have a positive FAS, that is, we see some sort of fluid collection or blood collection in the abdomen, the patient should be emergently rushed to the operating theater. So speaking of some numbers, again, fast exam, the sensitivity is 94.6% and specificity of 95.1% with an overall accuracy of 94.9%. So we can see why it has rightfully nearly replaced DPL as the primary modality. So the various areas, the right upper quadrant, Morrison pouch, the first place, as we went through earlier, first place where the fluid would collect in a supine patient, and the subxiphoid view for pericardial fluid, for the view of the heart, the view through liver, it can be transhepatic or parasternal. And then the left upper quadrant, that is view between the spleen and kidney. That is another dependent place where fluid collects. And we can also see the diaphragm in this view. And then there is the bladder view, which will evaluate for the fluid and pouch of Douglas posterior to the bladder. It is again a potential dependent space. Now, other modalities, there is DPL, diagnostic peritoneal lavage. There is the CT scan of the abdomen. There is paracentesis. So diagnostic peritoneal lavage, DPL, it has been extremely reliable, up to 98% in determining the presence of blood in the peritoneal cavity, and it can also give us an idea about the rupture of hollow viscus, that is the intestines. And again, once it is positive, patient should be right away taken to the operating room. CT scan, it can be used for diagnosing intraperitoneal injuries, and although in stable patients. And it can give us a good idea about the injury to the solid organs. Paracentesis, 4 quadrants are aspirated, and a positive tab would be of blood, air, or bile. However, again, there can be significant negative taps up to 20 to 60%, and therefore the negative taps cannot rule out injury. So it is a highly non-specific, non-sensitive. So coming to DPL, it has been the gold standard for investigation of blunt abdominal trauma for more than 30 years. When can we consider DPL as positive? So the conditions here are the return of 10 ml of non-clotting blood, lavage count of more than 1 lakh or 100,000 red cells per mm or 500 white cells, the mileage of the collected fluid if it is greater than 200 international units, or any presence of bile or feces of bacteria. So there is a small graphic here showing the technique of the DPL, the incision site usually is 1/3 way down from the umbilicus to the pubic symphysis. There definitely are some contraindications to diagnostic peritoneal lavage, and since it is an invasive procedure, there definitely can be some complications as well. So coming to contraindications, the first and foremost contraindication is pregnancy. Again, morbid obesity can be a contraindication. The complications can be perforation of the gut, since it is invasive and we are inserting something sharp into the abdomen. So that itself may cause perforation of the gut. It can lead to hemorrhage and it can lead to infections. Coming to CT scan, first and foremost, it is suitable for the patients who are hemodynamically stable. We cannot shift unstable patient in shock to CT. It can show the solid organ injury with a specificity of around 95%. It will help us determine the source and the amount of bleeding, and it can reveal other associated injuries like the vertebral injury, pelvic injury, or thoracic injuries. Will provide us with an excellent imaging of pancreas, genitourinary system, and the duodenum. So here is a sample photo of CT scan showing the lacerated liver here. So you can see there is a hypodenser, a black patch in the liver, and a right-sided pneumothorax. So a comparative slide for diagnostic peritoneal lavage and fast versus the CT scan. So as we can see in CT scan, again, firstly, the BP should be normal. DPL and fast can be performed on hypotensive patients. Fast is non-invasive, can be done on all the patients, although it is operator dependent, and bowel gas and air, it may cause distortion of the image. For the peritoneal lavage, it can detect bowel injuries if there is any bile or any fecal matter that is aspirated. Diaphragm and retroperitoneum will be missed, both in fast as well, specifically in fast, as well as in the diagnostic peritoneal lavage. So coming to specific injuries, let's speak about liver trauma. Since liver is the largest organ in the abdominal cavity and continues to be one of the most commonly injured organs in patients with the abdominal trauma. So the diagnosis, first of all, any penetrating injuries, any gunshot, any stab or shotgun wound below right nipple on the right upper quadrant of the abdomen, it can cause a hepatic injury. Anything on the lower ribs on the right side, it can cause hepatic injury. So diagnosis can be, usually it is made by laparotomy in patients that usually present with penetrating injury which require immediate surgery. The diagnosis of hepatic injury usually will be made at the time of laparotomy. In blunt trauma, the patients who remain in shock, who have abdominal rigidity or guarding, again, usually the liver trauma, the hepatic trauma will be diagnosed on laparotomy. The other diagnostic tests, as we spoke, CT is a very helpful modality which can help us determine the nature and extent of the hepatic trauma. So patients sustaining any significant right lower thoracic injury, right upper quadrant injury, or epigastric blunt trauma, they should be suspected of having a hepatic injury. Clinical assessment is important. Abdominal paracentesis can help. The peritoneal lavage, they can help. If the patient is stable, CT scan can give us excellent pictures and help us determine the nature and the grading of the liver injury. The initial management, however, in all patients have to be performed the same way. Resuscitation has to be performed the same steps. The ABC has to be seen. And the patient should first of all be resuscitated and managed according to the trauma protocols. So there can be a non-operative approach for liver trauma. The hepatic injury, if it is diagnosed by CT in a stable patient, the non-operative approach is usually standard in a lot of centers. CT criteria for non-operative management has been given here. If there is a simple hepatic laceration or there is a small hepatic hematoma, there is no there is no evidence of active bleeding, or the intraperitoneal blood loss is less than 250 ml, and there is absence of other intraperitoneal injuries that may require surgery. The patient can usually be managed with a non-operative approach. However, coming to operative approach, in case there is persistent hypotension despite adequate fluid replacement, volume replacement, which suggests usually an ongoing blood loss, that will require an immediate operative intervention. So the injury classification, it can usually be done on the basis of the operative findings in such patients, or in stable patients, again, by the CT findings. So all the patients undergoing laparotomy for trauma should be explored through a midline incision. So coming to the classification of hepatic injury, there are 5 grades. Grade 1 is simple injuries, which are non-bleeding. Grade 2, again, simple injuries that can be managed by superficial sutures. Any major intraparenchymal injuries with active bleeding will be classified as grade 3. However, if such injuries, they require some inflow occlusions, that is, we do a Pringle maneuver. If such a requirement is there, that injury will become a grade 4 injury. If there are juxtahepatic venous injuries, the organs around the vessels around the liver are also damaged, that will become the most serious, and they will be classified as grade 5. So the management, grade 1 and grade 2, they can be managed by a variety of methods like simple sutures, electrocautery, or topical hemostatic agents. Mostly they will not require drainage. If there is a grade 3, so we can do a ligation or repair of the injured blood vessels and bile ducts under direct vision, or obviously on laparotomy. Grade 4, again, extensive intraparenchymal injuries, they will require this occlusion of the portal triad, that is the Pringle's maneuver, to control the hemorrhage. So summarizing everything, simple techniques in management of liver trauma. That includes drainage of only non-bleeding injuries, application of fibrin glue. There can be sutures, hepatography, or surgical sutures. That is for grade 1 and 2. Beyond that, grade 3 and 4. 4 is that are all performed with the Pringle maneuver in place. These are some examples of the interventions done: extensive hepatography, an ventral pack, or hepatotomy, or if needed, even resection or resection debridement has to be done. Selective hepatic artery ligation can help us control the blood flow, and perihepatic packing can be done. So complications of all of these procedures following the trauma can be recurrent bleeding. Patient may bleed again. There may be hematobilia, that is leakage of bile into the blood. They can be perihepatic abscesses, biliary fistulas, intrahepatic hematomas, obviously coagulopathy, and if there is extensive damage to the liver, a patient may land up in hypoglycemia or recurrent hypoglycemia due to hepatic failure. Now coming to the most commonly injured organ, that is the spleen. It remains the most commonly injured organ in blunt abdominal trauma, and it is very frequently involved in penetrating wounds of the left lower chest and upper abdominal trauma. But again, even in blunt trauma, the spleen is the most frequently injured. And again, we will come to the grading of the injuries. But first of all, the management of splenic injury, that has drastically changed over the past decade. Now, since the spleen is recognized as an important organ in the immune system of the body, as well as the RET filter, so splenectomy is usually avoided if present in children less than 2 years, in recognition of this overwhelming post-splenectomy sepsis, that is OPSS. So usually in children less than 2 years, any sort of splenectomy would usually be avoided, and we try to conserve the spleen by splenography. Now, since it is the most commonly injured organ in the blunt abdominal trauma because of the mobility, stab wounds, gunshot wounds will cause simple lacerations, but again, that is beyond the topic of today. So interestingly, 2% of patients undergoing any surgery to the left upper quadrant of the abdomen can also sustain an intraoperative injury to the spleen. Now, to determine the grading, the magnitude of splenic disruption, it will depend on the patient's age, injury mechanism, presence of underlying diseases. So, but the splenic injury broadly has been graded according to the pathologic anatomy into the 5 parts, that into 5 grades. That is, grade 1 is subcapsular hematoma, grade 2 is subsegmental parenchymal injury, grade 3 is segmental devitalization, grade 4 polar disruption, and grade 5 will be shattered or devascularized spleen. 1 and 2 usually we will manage with a non-operative approach. In grade 3, the angiography will be done and angioembolization, and if required later on, we can go on to a laparotomy. Grade 4 and grade 5 injuries usually will be managed with a laparotomy with either a splenic salvage or a splenectomy. So important things again, patient factors, that is the patient history, physical examination, radiological evaluation, chest X-ray, the abdominal X-ray, CT scan, angiography as we spoke. These will give us important clues to the grading and the severity of the splenic trauma. So there is a CT scan showing a small splenic laceration, which would normally be managed non-operatively. Another injury, slightly larger. So the initial management again remains the same. Resuscitation has to be done as ABCD. Non-operative approach, again, as we spoke, pediatric population suffering trauma will usually be managed with a non-operative approach. All the measures will be done, like splenography and everything, to conserve the spleen as much as possible. So the important criteria for non-operative approach would be a hemodynamically stable. Child or adult have to be hemodynamically stable. The patients without any peritoneal finding at any time, and the patients who will not require more than 2 units of blood. Contraindications for splenic lavage can obviously be protracted hypotension. That is, the patient's blood pressure is not improving despite all the measures. Any undue delay is anticipated in attempting repair of the spleen, or the patient has other severe injuries that can be contraindications for the splenic salvage. About the operative approach, the decision to perform splenectomy or splenography, it will usually be made after assessment and grading of the splenic injury. So again, following splenic trauma, following post-splenectomy, there can be some complications classified into early and late. The most common early complication will be bleeding. Then there can be gastric distension, there can be gastric necrosis, there can be recurrent splenic bed bleeding. After splenectomy, due to compromise in the blood flow, there can be pancreatitis, there can be subphrenic abscesses. Some of the late complications will be thrombocytosis. Again, the OPSS, as we spoke about, usually occurs 1 to 6 weeks later, and deep venous thrombosis. So again, now coming to the kidney, the genitourinary system, we'll speak just about the kidneys here. The kidney injuries, they are rarely seen but are not very unusual. They lie in a well-protected area, lie in the retroperitoneum. Any forceful blows, as we saw in the previous slide, forceful blows or any penetrating injury, usually we can have the kidneys involved. So we need to suspect kidney damage if a patient has history or physical evidence of any of the following. Any abrasion, laceration, or contusion in the flank, the great on a sign that we spoke of. Penetrating wounds in the region of flank or the upper abdomen, fractures on either side of the lower rib cage or lower thoracic or upper lumbar vertebra, or again a hematoma, frank hematoma in the flank region. That can give us a indication that there may be a kidney damage. Now, concluding everything, say abdominal trauma can obviously be very difficult to evaluate in a pre-hospital setting. So a high degree of suspicion based on the mechanism of injury and other patient factors there has to be a high degree of suspicion. And mostly the death from abdominal injury will result from hemorrhage and delayed surgical repair. So as we spoke earlier, the three keywords for pre-hospital management have to be scoop and run. So abdomen, it is a black box. It is impossible to know what specific injuries have occurred at the initial evaluation. Proper imaging or if needed a laparotomy that is required to know exactly what is going on inside the abdomen, specifically in the blunt abdominal trauma. So key to saving lives in abdominal trauma is not to make the accurate diagnosis, but to recognize that there is an abdominal injury and to facilitate rapid transport to a hospital where the patient can be further evaluated and managed. Right? So again, key to saving lives, you can see a cartoon here that whenever there is a chance of abdominal injury, do not delay transport. Again, the three keywords here, scoop and run. Okay, so that will be all for blunt abdominal trauma.